Welcome, everybody. Thank you for coming to this presentation. This is probably one of my favorite topics. I'm going to talk about tube feeding complications, and not once am I going to talk about diarrhea. So I'm going to change the game here a little bit. So I like to know who my audience is. Can you raise your hand if you are a clinician, nurse, or dietitian? Okay, great. Keep your hand up if you are a dietitian. Okay, great. And there's physicians in the room too. You guys can raise your hands. Dr. Mundi reminded me of that with his, hey, don't forget about us over here. Okay, great. So I have some objectives here that we're going to talk about. I do have a disclaimer. I have some pictures here in this presentation that are pretty graphic in terms of we're going to be looking at tube site complications, okay? So usually I follow Dr. Kelly in this presentation, and she has really cute animated Despicable Me pictures. So I usually have a hard act to follow. What's that? About diarrhea, right? So I get to start off today, so I get to set a tone here. The overall message is that tube feeding shouldn't hurt, and so my goal is to empower the clinicians in this room and the consumers in this room and the family members in this room to advocate for whoever's on tube feeding that is having problems or complications at the tube site, because I've seen too many people wandering around with complications that people thought were just a normal byproduct of having a feeding tube. And, I'll talk a little bit about setting yourself up for success, like creating a plan that works for you so you can actually meet your weight gain goals, meet your calorie goals, things of that nature, because what happens in the hospital, the protocols don't usually translate well to home. So we like to sort of strategize to meet your needs at home as well. And that goes for devices as well as your feeding regimen. So I'll talk a little bit about some adapters and things that are what I refer to as home care friendly. I talk about moving a hospital regimen through a home care friendly filter to make it achievable at home. And it's not always the same devices that we use in the hospital. It's not always the same regimens that we use in the hospital, but there's some adaptations that need to occur for success in the home. And then I'll touch very briefly on ENFit transition update. So I said I wasn't going to mention diarrhea, but here it is. It's my obligatory diarrhea slide. So this is normally how we monitor tube feeding tolerance. As dietitians, we're looking for nausea, vomiting, diarrhea, constipation. But when are we ever really looking at the tube site itself and the health of the tube site? Because that is what I have found to have some of the biggest impact in a patient's relationship with their feeding tube and their experience on tube feeding. So I know from experience that there are a lot of physicians out there that don't like to manage tube feeding patients at home because they're a little bit out of touch and out of sight, and we don't have the ongoing acute clinical monitoring of our tube feeding patients that we do with TPN. With TPN, we're checking labs, we're in clinic. Many times with tube feeding patients, they're home and stable and sort of doing their own thing, so they're a little harder to manage. And really the bottom line is that it's the home care clinicians, the home care providers that become the link to those physicians to help provide feedback about how things are going. So it's really important that those clinicians, whoever they are, have a really good understanding of how to manage some of these complications. So my goal when we're done is to have you all sort of indoctrinated into my club. I have my ulterior motives here today. So I want to tell you a little bit about Debbie. Debbie is a long-term tube feeding patient. She's 78 years old, and she presented with this, I'll refer to it as a funky tube site. Okay, this was sort of normal for her. She would clean it, but at the end of every day it would look red, irritated, and would have some gunk sort of building up over there. So there's what would build up for her. And so, this was the picture. We do some sort of tele-troubleshooting, right? So I'm trying to figure out what is wrong with this tube site, and it looked like it was probably a little bit too tight, but it wasn't too bad, so I wasn't exactly sure. I couldn't quite figure it out. So random act of luck, I happened to be in her neighborhood on a Sunday, and I asked her if I could come by, so I did. I went and visited her, and I had a conversation with her. I wanted to learn about her life on tube feeding. And she had a leaky tube, and that's why she called us, because she was complaining of this leaky tube. She was certain there was something wrong with her tube. So what I learned after meeting with her was I wanted to understand her protocol at home. And she's a bolus feeder, and this is a Mickey button, and so she had little extension sets that she would plug in. Let me go back into, get the right button here. So little extension sets that plug right into there, right? But in between feedings and right after feedings, she was having this leaking that was going on. So I wanted to understand the volumes, because the first thing I want to look at is how much are you actually putting into the feeding tube. So I had her show me how she does her feeding, and she did what I had never seen this before, but it was a power feed like I've never seen, where she would draw up formula and pushed it through so fast it made me uncomfortable watching it happen. So she put 4 syringes through, and she was getting ready to do her next carton of formula. She does 2 containers 3 times a day. But she would also do some hydration, and she'd put some Pedialyte in there, about 4 ounces of Pedialyte, a couple of containers of formula, and then she would normally do some water after that. But I stopped her after the first carton of formula so that we could talk about the rest of her protocol, and this is what it looked like. 4 ounces of Pedialyte, 8 ounces of formula, another 8 ounces of formula, 8 ounces of water, another 8 ounces of water, and then 4 ounces of water. And she's 5'3", about 120 pounds. And I wouldn't have believed it if I wasn't there. So I stopped her after a carton, and I talked about, volumes, like what's the normal volume of a stomach, and what she is putting in her stomach. She didn't really have the concept of how much that was, so I had her get a mixing bowl out of her kitchen, and we simulated it with water. And then I held that bowl up to her stomach and showed her how much that was. It was 1.25 liters of formula in about 5 minutes flat. So that is when I learned and figured out why her tube site was leaking. She was overfilling her reservoir. And so when I explained it to her that way, the light bulb went on, and she laughs at me and says, "Oh, well, that explains why when I bend over to pick something up after a feeding, I vomit." Because she would fold her stomach in half, and then just everything would come out. So she doesn't have time for watering and feeding. This is her words. It's how she puts it. She's busy. She doesn't want to spend all this time watering and feeding. So, but she was having this very poor relationship with her tube as a result of how she was doing this tube feeding. So we had to negotiate, and we worked on slowing things down and spreading her hydration out throughout the day. And then we worked on a plan to work on that yeast infection, which I'll talk about in a minute, because that's what's going on there. She had a yeast infection, which is why this is so red and inflamed, from all the moisture. She was overfilling her reservoir. So this picture doesn't show it quite so well, but after a couple of weeks with an antifungal, slowing down her feedings, not having the leaking coming out of the tube site, her tube site started to heal. She had been using an antifungal. She had some at home, but the way she was applying it, it wasn't working. And I'll talk about that in a little bit as well. So there's some very specific details that needs to happen with our patients when we're educating them. And she taught me that lesson as well, is to be very specific with the teaching. So we'll talk about that in a minute. But first I want to introduce you to David. He's my other educator. He taught me a lot. Both of these people came into my life about the same time. He was a very that's my emoji. This is on behalf of my daughter, who's 13. She loves emojis. And this sort of illustrates the way he was at the time. He was very much an unhappy camper because tube feeding was very unpleasant for him, and he was not gaining weight. He was very underweight, as you can see there, and he had this constant foamy reflux and coughing that was occurring with his feedings, so he was not compliant. He would feed his formula and then wouldn't do the whole prescription because he was constantly refluxing. And like I said, this foamy reflux to the point where he wouldn't leave the house because he'd have to spit into a napkin all the time. And so he wouldn't go drive. He could drive, he just wouldn't go anywhere because it was too depressing for him. So he complained that that was occurring, and his tube site was frequently gooey because whenever I talk to somebody on the phone, when we're working on a regimen or working on something to make things better, I ask, how's your tube site? How's it looking? And so he said, well, it's kind of gooey. So we got some pictures. And what you can see here is a little bit of goo going on here. And this is what it looked like after it cleaned up. So this is not an infection, but it's a result of what's going on right here at the stoma site called hypergranulation, which we're going to talk about a little bit more in a minute. But the reason he had this hypergranulation was because his tube was too big, so we had to resize him and get it fitted. But this ooey gooey was sort of a problem for him as well as that reflux, and he wasn't gaining weight. So he had all of these problems going on, and he wasn't successful at home with his tube feeding, and he just needed a few different changes. But what he was doing at home was putting on some triple antibiotic ointment, because that's what you do, right? When something's ooey gooey at home, just go buy some triple antibiotic ointment. It wasn't working. He was cleaning his stoma site with a sterile alcohol swab as well, which is actually part of the reason why this developed, this hypergranulation. So he wasn't cleaning properly. And he was using a lot of gauze because he was having to clean up the ooey gooey. So what I did for him was worked a strategy where we changed him to a higher calorie formula so he didn't require so much to get the calories he needed. He also liked to blenderize formula as well, and he wanted to start doing that again. And I came up with a program where he would do most of his calories from the formula, but he also would blenderize his own. He was a chef in a former life, which was so cool because he could make his own food. And then he would freeze it into ice cube trays, and he would do his 6 cartons of formula per day and 10 cubes a day of his blenderized formula. So we worked that out, and that's when he started to gain weight again because he was then compliant and slowed down his tube feeding as well. He was power feeding like Little Miss Not So Speedy, my other patient. And so once he slowed things down, and then the last ingredient to his success was I worked with this physician to get him on an anti-reflux medication, and that was a game changer. The reflux went away, he stopped with the foamy reflux, and he was able to go out and drive around and visit family and visit his friends and do all the things that he liked to do. So that's David's story. And this is my little pause. This is actually a picture of an Oley attendee, and I'll let you spend the rest of the week trying to figure out who it is. You have to walk around interviewing our tube feeding ambassadors with Oley. But I love this. He has this tattooed on his stomach, you guys. Caution, do not overfill. Warning, exhaust fumes may be deadly. He recommends not hiking behind him on a trail. But this is just a reminder to slow down and respect your reservoir. Respect your anatomy, respect your body in a way. Even though tube feeding, is not something that you really want to spend most of the day doing necessarily. If you have to bolus feed, you still need to keep in mind, how big is your stomach, which Little Miss Not So Speedy, that's what I nicknamed her, because her friends called her Speedy, but I renamed her Little Miss Not So Speedy, so she would slow down her feedings. She actually asked me, because she was trying to push the envelope, well, how big is my stomach? Because I told her 1.25 liters is what you're putting in your stomach. She says, well, how big is it? Because she wanted, of course, to get to the limit. And so I had to do a little research, and because I didn't know, actually. So I found out that the average stomach size is 0.94 liters, so just under a liter. She's 5'3", about 120 pounds, so hers was probably about 0.75, which was about 3 cartons of formula, which I'm sure she was already figuring out that math. So all of that to say that it's really important to keep that in mind and to respect your anatomy and to be kind when you're doing your tube feedings, and don't power feed too fast. Most of the time we're worried about people going too slow. We're rarely worried about them going too fast at home. But let's talk about what is the normal healing of a G-tube site, because what you're going to see after this is complications at the tube site. But it should look like a pierced ear. Normal flesh color, not red, not inflamed, nothing funky growing off of it, right? Should look very normal. So if yours doesn't, and it's uncomfortable, it should probably get looked at. PEG site infection is the most common complication in the literature, ranging from 3 to 30%. Bacterial infections and others. The factors that may increase the risk of infection are diabetes, obesity, malnutrition, chronic steroid use. All of these things suppress our immune system and our ability to fight things off. We'll talk about bacterial infections first. Honestly, it's the least common thing I see, but this is what it could look like. This is another one. This is the worst bacterial infection I encountered. This was a patient that had been living with this baseline for 10 months and kept going into the GI doctor asking for a new tube because there must be something wrong with my tube, right? Well, as it turned out, the tube site, that's what this crusty, gooey, stringy, this picture's upside down, I think, but you can see the sort of the stringiness of it. This was baseline for her for 10 months, and so when we realized that she had a bacterial infection, we recommended to her physician an antibiotic, and so that we actually went systemic with that through the tube. Normally, with a smaller bacterial infection, a topical antibiotic, prescription grade, not triple antibiotic ointment, but prescription grade will actually do the job. But in this case, because it had been so long-standing, we went big guns with her. I think the worst part of her story, though, actually, is that she had been bolus feeding at home without a home care company, by the way. She'd been doing this on her own, buying an oral supplement at the store. She's a Medicare patient. And so when we encountered her, we realized, okay, she actually does qualify for Medicare coverage, so we were able to get her qualified and get her set up and get her on a proper formula, one that's designed for tube feeding and not oral supplements. And then the antibiotics, but the worst part, I think, is the fact that she had been bolus feeding with a 12 cc syringe for a year because she didn't know that they had bigger ones, and that was her life. She would use those little itty-bitty syringes to feed with, so we changed her life with a prescription, a 60 cc syringe. She didn't have to pay for the formula over the counter anymore. It was a good outcome. But all because she was sort of at home, not connected to a company, not connected to caregivers or healthcare partners in her journey that knew better. So hypergranulation might be the most common thing I see, actually. These are sort of the clinical descriptions of what you're going to see here in a minute. But hypergranulation, there may be somebody in this room who's been told by their physician that it's normal and that it's just part of having a tube. I disagree, and I have a problem with that because I've never met somebody who had hypergranulation that didn't find it uncomfortable. It's not benign, in my opinion, because it causes other problems, so it needs to be addressed. But it's very vascular, and it can bleed very easily, which we'll see some examples of that. What causes hypergranulation? The tube moving around too much, a poorly fitting tube, using rubbing alcohol or hydrogen peroxide every day for cleaning will actually grow hypergranulation. Sometimes it's the body's own response to that prosthetic, but usually there's some other underlying cause, in my experience. So I usually lead with a conservative approach with hydrocortisone cream applied directly to the hypergranulation, and that will usually sort of beat it down over a couple of weeks. But sometimes patients don't tolerate hydrocortisone cream. I was just talking with one of our dietitians before I came down, and we have a patient who's not tolerating and it's not responding well to the hydrocortisone cream. So we're going to go to the next option, which is silver nitrate application. And that's something that would be done by a nurse or a physician and not by the patient specifically. Or if it's too big of hypergranulation, then debridement or cauterization is recommended. So this is a very classic presentation. It's sort of got that spongy look to it. And in this case, this patient's bolster was set too far back, and so the movement in and out and in and out is what caused that hypergranulation. This is another example. You can see here this little proud flesh, right? That's what's growing. And you can see, here's your clue, this bolster is way too far back. So that tube moves in and out and in and out and in and out. And that sliding, the friction right there against that very sensitive, tender stoma tissue is what grows that hypergranulation. So what do we do with hypergranulation is that application twice a day of the hydrocortisone cream and then re-educating. Always when we find complications, we have to re-educate. And the education is about just use plain soap and water, don't use any fancy alcohol wipes or anything like that. Is that me already? That means I have 2 minutes, right? No, it's not me? Okay. So that hydrocortisone cream and then re-educating around how to clean it and how to set that bolster, making sure it's set properly so there's not too much movement. So now I want to talk about yeast infections, and again, this is probably runner-up with the hypergranulation of one of the more common things that I see. And it's a fungal infection of any of the Candida species, and again, these are the clinical descriptions of what you're going to see on the next slides. But it's the difference between bacterial infections and yeast infections is that bacterial infections don't hurt, where yeast infections can be very painful, and you'll see why in a minute. But there could be secondary lesions. Sometimes the skin looks like it's peeling away. It usually gets very bright red and looks very painful, and it generally is. And there could be little satellite lesions. What causes yeast? Well, there's a few key ingredients to grow yeast at a stomacite. One is excessive moisture. The other is a dark environment. And then lastly, a nice warm environment. Doesn't that sound like underneath your shirt where your stomacite is? It's like the perfect recipe. So that's why making sure if you've got a leaky tube that gets resolved, or if you have bleeding at the stomacite, that gets resolved, because otherwise you will wind up with yeast infections. So how do we treat yeast? You need an antifungal. There's prescription and over-the-counter versions. So Lotrimin is an example of a prescription, over-the-counter, where nystatin is an example of a prescription grade, and they both work similarly, different mechanisms, but similarly in that they sort of destroy the yeast cell wall, so they become leaky and they die, and that's how the yeast gets cleared up, is with these medications. But when we have a yeast infection, there's usually some sort of leaking, so barrier cream could be an important ingredient in the resolution of that tube site infection. Hydrocortisone cream can work on the red, inflamed areas, and then the antifungal is necessary to kill the yeast. And oftentimes we need all three of these things. They're all twice-a-day applications, and they need to go on rotation, right? So I'll show you some examples of some patients where we used this protocol and recommended it with the doctor and got them on this program for resolution. So this was a patient that presented actually with some severe bleeding at the stomacite. And once we cleaned up and had the patient retake a picture for us and show us what was under that bolster, you could see this satellite lesion here. The skin is sort of macerated. There's, it's got this sort of peeling look to it. It looks very red and painful. Okay, this is not a bacterial infection. This is a yeast infection. But there's a little clue in here about what caused this. Right here at the stomacite, there's an itsy bitsy, teeny weeny little hypergranulation in there. They're like snowflakes. They come in all shapes and sizes, but this one created a mess because it would bleed so easily because it's so tender, so fragile, and then would just create a mess here with moisture and with that warmth, and in the darkness grew this yeast infection, which was very uncomfortable for this patient. So what do? Well, until this stops bleeding and the moisture is resolved, a BID application of a barrier cream, so twice a day, put some barrier cream on there. Twice a day, put an antifungal cream on there. And then the hydrocortisone cream on the red inflamed areas, as well as on that hypergranulation. Within 2 weeks with some hydrocortisone cream on here, usually we can beat down that hypergranulation to where it doesn't exist anymore. So this is what it looked like with that protocol. All three of those creams on rotation, making sure to wipe off the barrier cream before putting on an antifungal. That's what Little Miss Speedy taught me. Little Miss Not So Speedy taught me. Is her antifungal wasn't working because she would layer it right on top of her barrier cream. So that reminded me to get very specific with my teaching to make sure that they're alternated and cleaned up in between. And you can see within a month and a half how much better that tube site looked. Okay, well, we're on mold, so we're almost done. All right, so occasionally we see mold in the tube. To me, that's a red flag for we need to re-educate on flushing, proper flushing, making sure that we're using that water sandwich concept, so water, feedings, water, medication, water. If you're using juice or foods, water, juice, water, whatever you're putting through the tube, make sure you sandwich it with water. Don't stick anything into that tube to try to brush it out of there because it's embedded in the tube. So there's no way to get it out of there. So what it means is it's time for a new tube. And so if we identify something like this in our monitoring of patients, we're recommending that that patient get a new tube placed, or it will get brittle and crack on Friday night at 10 o'clock, right? This was an interesting case where our dietitian who was monitoring the patient was doing her monthly check just to see how things were going with tolerance, and then asked about the tube. And the patient said, I'm flushing my tube, but this stuff won't flush out. And I flush it, but it won't come out. So we got some pictures, and so what we determined with this is that this is tube degradation, and it's time for a new tube. So again, it's one of those cases where we need to advocate for the patient to get their appointments and get a new tube placed, or this tube will fail as well. And what I learned later, actually, is what this can be caused from is yeast colonization. So if you've got yeast infections going on the tube, it can actually colonize through the tube and then degrade the tube. So it's important to keep that healthy. These are some home care friendly adapters that can be used. Here's an example. Instead of something like this, we had a patient that came home with this teeny tiny tube and they just had this little plug in it. So in home care, we try to make things home care friendly. They needed a little adapter. And then these were just weird combinations of connections that we encounter in the home setting. And so we solved some of these problems with little, like I said, little home care adapters. This is one that we would see in the hospital, but this is a home care friendly version, things like that. And I'm kind of out of time, so I can't really talk about our ENFit transition, I guess. You guys are kicking me off stage? Are we done?
Let's do just do a transition.
Okay.
ENFit is such an important
Okay. So, all right, I'll try to keep it short, because I know we are going to talk more about ENFit, but really all I have to say about it is we're in transition, as you know. I want to orient you to some language. You may have a legacy set right now. This is a feeding tube that has that standard opening. We refer to that as a legacy feeding tube. The feeding bags themselves used to look like this, right? And now they have this little ENFit connection with a white Christmas tree adapter. So we're sort of in this transition set phase. If you've got a legacy tube, you're plugging this transition set in if you're pump feeding. And then future state or current state for some folks, if you have an ENFit tube, which is what this piece is, the feeding bags and syringes can plug right into that. And so the purpose of ENFit is to create a connection that's not compatible with IV connections. ENFit is designed to keep tube feeding connections just compatible with tube feeding products and to make them incompatible with IV connections or other connections so that there's not a misconnection and so we don't wind up tube feeding into an IV line, which has happened. And so that is the purpose of it. So the syringes are also necessary in order to flush feeding tubes and administer medications. So if you've got an ENFit tube, you need an ENFit specific syringe. And for us in home care, we have to make sure that our stuff connects to your stuff, so we're always looking to make sure we know what sort of tube you have, or if you transition to a new tube at home, we're providing you the compatible pieces so that you can actually successfully tube feed. So we talked about the language that we use if you have a legacy tube, or if you have an ENFit tube, and they also have hybrid tubes out there where one port is ENFit and one port is legacy. We do know that there are some challenges with the transition just with regards to providing supply chain management throughout the continuum of the healthcare journey that a patient may make has been one of the areas in which has slowed down the transition, and some of that has been mostly contained within the NICU or the very small low-dose infant syringe sizes and delivery systems, and translating that from hospital to home. So we have had hospitals that have transitioned. We've got some children's hospitals where in the NICU, all they're placing are ENFit tubes, but we haven't seen it across an entire hospital system just yet. And I know that there's some research, the last thing I'll say is that there's some research being organized right now to develop a cleaning protocol for the ENFit tips, and that will be studied in the acute care setting, so we should see some publication on that by January, and then we can translate that into home care about the cleaning efficacy and safety. So that's it. Thank you, everybody.